Everybody, welcome to Commonsense Urology, where I'll go over common urological problems and offer a sensible approach to diagnosis and management. I'm Dr. Neil Gordon, and today's topic is hematuria. If you like what you hear and see, please give a thumbs up and consider subscribing. Don't forget to click the notification bell to hear of many more episodes to come. When a patient presents with hematuria, clearly it's macroscopic hematuria because a patient cannot see microscopic hematuria. Microscopic hematuria is usually picked up by the doctor who's doing a routine test for urinary tract symptoms or for a general physical examination. Now, with macroscopic hematuria, particularly in a man, it's a good idea to get an idea of when the hematuria occurs. If it's at the start of the stream and clears afterwards, quite often it's of a benign nature and comes from the prostate. Often though, in both sexes, it can be a urinary tract infection, and if it's right through the stream, it can certainly be related to the upper urinary tract as well. Now clearly, it's worthwhile having the urine examined by the pathology laboratory. They'll look at the red cell morphology. If the cells are dysmorphic, as in beaten up and wrinkled, then it's likely to be glomerulonephritis because the red cells get damaged when they're being burst out through the glomeruli. Lower tract disease or collecting system disease is more likely to have universally well-shaped red cells. Now, the causes of macroscopic or microscopic hematuria are many and varied. And I've never forgotten when I was a medical student and physicians used to say, "Oh, what are the causes of this," as in hematuria. Now, I've compiled a little list of how I used to go through things, and that's screening in a moment. I compiled a list which I called the I list because everything began with I. Way before cars had I this and I that in front of their names, and before telephones, computers and other instruments had any of that sort of lettering at all. So there isn't a patent on the letter I, so mine continues as well as theirs. And clearly, going through the list, you can see that any number of the things on that list can apply to hematuria. Infection, yes. Infarction, certainly. Infiltration, primary or secondary tumours. Inherited. Bleeding disorders such as haemophilia. Injury, of course, that makes you bleed. Immunological conditions such as lupus, and alcoholics can often have clotting diseases, and some patients will have too much in the way of anticoagulants in their system. Now, idiopathic ones usually turn out to be such things as an AV fistula or some unusual finding, and you won't find many of those within the urinary tract. Iatrogenic, of course, passing a catheter can cause hematuria, but if there's a catheter present, then that's fairly obvious. But procedures carried out laparoscopically or open laparotomy procedures can lead to ureteric damage and hematuria. And the last one we called endocrine, just for completion, but it does mean also metabolic, and things such as renal calculi can, of course, lead to hematuria. Now, investigations. Usually hematology and biochemistry are carried out, as well as liver function tests. It's not necessary to carry out coagulation studies in the majority of patients. If, however, they are on anticoagulants, then it's a good idea. The main two investigations are a CT urogram, that's a urogram with contrast, and a cystoscopy. Now, some patients are allergic to contrast. It's unusual that they are allergic to low ionic contrasts, and there's a protocol available for patients who require contrast to reduce the risk of allergic reaction. The protocol consists of 13 hours prior to the procedure being performed, 4 milligrams of oral dexamethasone, a further 4 milligrams of dexamethasone at 7 hours prior to the procedure, and another 4 milligrams 1 hour prior to the procedure. Also given is 150 milligrams of ranitidine and 10 milligrams of Zyrtec. Now, these medications can make the patient feel drowsy, and so the patient should be driven home from the radiology department. So usually after the CT has been carried out, even if it shows no collecting system lesions, a cystoscopy is warranted because small polypoid lesions don't usually show on CT. The cystoscopy can either be carried out under a general anaesthetic using a rigid instrument or with a flexible instrument under local anaesthetic. If there are lesions seen in the upper tracts, it is possible, but only under a general anaesthetic, to pass a flexible ureteroscope up to the kidney and have a look at those, therefore sample or biopsy. Now you will notice that I've not included cytology. Cytology is not an investigation of haematuria. Doing cytology requires the patient to attend the lab on 3 separate days and provide fresh specimens, not the first morning one. It does not alter one thing that you do. You will still do a CT and a cystoscopy. It's not helpful in differentiating the possibility of a transitional cell or urothelial tumour. It's only good for finding very undifferentiated tumours, and therefore, as I said, does not change what you do, so I do not include it ever in my investigation of haematuria. Most reasons for haematuria are benign. As men get older and are over 50 or 60, they're more likely to have benign prostatic hyperplasia, and that's a very likely cause of haematuria. In women, it's more likely to be estrogen deficiency, urinary tract infection, and perhaps urethrotrigonitis. The 2 most common malignancies that cause haematuria within the urinary tract are urothelial or transitional cell tumours and renal cell carcinoma, often known as clear cell carcinoma. Now, I'm not going to go into all the renal tumours and urinary tract tumours that are possible, but they're the main 2, and you should be aware of those. Here are some flow diagrams that will assist you with diagnosis and management. The flow chart goes right through to occasionally, very rarely, it is necessary to carry out a cystectomy in order to stop the bleeding. But I can assure you that's very, very uncommon, but put in for completion so you know at what extreme we can have to go sometimes. This chart is more applicable to people working in the emergency department. The renal trauma presents to the emergency department. The next chart will be more appropriate for general practice. Now this chart is more applicable to those patients seen in a general practice clinic. Urothelium lines the calyces, renal pelvis, ureters, bladder and proximal urethra, and therefore any tumours of that origin can occur in those positions. CT shows urothelial tumour invading the left kidney and extending outside. This is a papillary urothelial tumour of the bladder, which is bleeding before surgery. It's being removed using a resectoscope, which is the same instrument used for a transurethral resection of the prostate. It's necessary to remove a divot in the bladder wall in order to do staging histologically. Now this shows a resection of the left ureteric orifice with a stone trapped in the ureter. This is the long-term appearance of a resected ureter. This shows a prostate cancer at the top of the picture and a large bladder cancer within the bladder. This is a urothelial cancer of the kidney. This kidney has a very large cancer and a few small ones also. This is the internal cut surface of a carcinoma kidney. The best form of treatment for clear cell or renal cell cancer is surgery. Unfortunately, chemotherapy and radiotherapy are not terribly effective. There is a lot of good work being done in immunotherapy, and so that could be helpful in the future. From the point of view of post-operative monitoring, these patients require a CT of the chest, abdomen and pelvis at least 6 monthly for the first 3 years. Metastatic disease usually occurs in the chest. However, there have been patients who've had cerebral metastases discovered. From the point of view of management of patients with bladder tumours, principally TCC or urothelial carcinomas, most of them are fortunately superficial and can be resected completely with a transurethral resection. Continued follow-up consists of regular cystoscopies. Every practitioner has his or her own schedule. Mine is 3 monthly for 12 months if clear, 4 monthly for the next 12 months, then 6 monthly up to 3 years, and maybe 5 depending on the original pathology. Just like a patient who has small sunspots and skin cancers, they require regular inspection. So too does the bladder after a diagnosis of urothelial carcinoma. After that, annual checks are a good idea. Every 2 years the patient should have a CT urogram. For more extensive disease and treatment, often the patients require chemotherapy or maybe radiotherapy, and sometimes the condition leads to cystectomy. Often there'll be reports of carcinoma in situ of the bladder. Now, carcinoma in situ is generally regarded as not being a very nasty thing to have. For example, on the cervix, where it can be cauterized, frozen, lasered or excised. In the bladder, however, it is a completely different disease, and it is often highly aggressive, can lead to invasive cancer very quickly, and therefore require more definitive treatment. Since the early 1980s, immunotherapy in the form of intravesical BCG has been a very useful preventative in the management of superficial papillary bladder cancer. What happens is that the patient attends weekly for 6 weeks, a catheter is inserted in the bladder, and the BCG is instilled in the bladder and left in place for approximately an hour, with the patient lying on the back for 15 minutes, right side 15 minutes, abdomen for 15 minutes, and then on the left side for 15 minutes. The catheter is taken out, and precautions have to be taken when the patient goes to the toilet at home. This is usually very successful in reducing the incidence of further bladder cancer. I think the most important thing about hematuria is to be able to describe the colour, and using colours of wine seems to be the best way. Tomato sauce colour indicates fresh arterial bleeding. With a claret colour there are usually clots, and a dilute version of that is burgundy. A rosé colour is common after transurethral surgical procedures, clearing to a blush. Riesling is normal, dilute urine. And strong black tea indicates clots which have almost dissolved. Occasionally, after a catheter has been inserted in a patient with urinary retention, the drainage will drain a Riesling colour and then a blush or rosé. Don't take the catheter out, as there is no need. The cause of this is the pressure being taken off the small vessels of the bladder and leaking of blood. It will stop with a good urine output. Thank you for watching this presentation on hematuria. I hope you enjoyed what you saw and heard. If you did, please give a thumbs up and consider subscribing. Don't forget to click on the notification bell below to hear of many more episodes to come. Cheerio!